Right, good evening, or good day rather. We're very pleased to welcome Eric Yarnell, who's giving some time to speak to the GNC on low-grade prostate cancer. I've known Eric for some time, Dr. Yarnell. He is a naturopath, graduated from Bastyr University, and has written several books, one of which I'm very fond of, the Naturopathic Gastroenterology, uh, followed by the natural approach to prostate conditions and natural approach to urology as well. A very accomplished person. He's president of Heron Botanicals and a core faculty member for the Department of Botanical Medicine at the Bastyr Center for Natural Health. Thank you, Eric, for talking to us. Over to you.
Thank you. Yes, I was showing off the Prostate Book, which took 10 years to write. And you can get this from Aeon Press, which is based in London. So that is, we have a connection with them, although this is published in the States, but we now co-publish with them to make it more available. And yeah, so this is very much a textbook. This is not for patients. This is filled with medical jargon and very detailed review of natural treatments, as well as, conventional approaches and some critique of those and whatnot. But it's, and yeah, there's an accompanying volume that's about sort of the rest of urology. But if you're certainly wanting to read more about what I'm going to talk about, I have very extensively documented that in that textbook. So, and yeah, I've been practicing now. This is my 26th year. And you've caught me the day before my 51st birthday, so that's exciting. And I feel like I've kind of finally gotten this prostate cancer thing figured out. So yeah, I've seen several hundred patients with prostate cancer, and the vast majority of this low-grade type, which I'm now to the point, as you can see in my slide, of putting the word cancer in quotes. So I'm going to kind of review why maybe calling this cancer is misleading, but we don't have a better word, so I'm going to default to using that word, and I'll distinguish the low grade from the high grade, and sort of what that looks like on the cellular basis, as well as sort of clinically how we sort of differentiate those. And then, of course, I'm going to talk about what to do with this patients who have this problem. And I hope to get through all that. So let's first start and just talk about sort of what is this low grade versus high grade prostate cancer and how to tell them apart, or sort of my proposal of that. And so this story really starts in the 1960s. With this medical doctor, Donald Gleason. And this is literally exactly what he drew, which to me looks like a kindergartner drew this. But he was looking at slides of prostate cancer under the microscope, and he basically, as you can see, broke them up into sort of 5 groups, depending on how they looked under a microscope to the naked eye. So it's really important to know that these grades are very subjective, especially the lines between them. There is not a definitive line. And we know this in part because if you give several different pathologists the same slides, they sometimes come up with different answers. So anyhow, this is the first clue that there's sort of more to this whole picture of what prostate cancer is, in that, well, already there's, he said there were 5 different types, and now kind of everyone is going to see has abandoned 2 of his types. So why do we think all the other ones were on the money, that were accurate? So yeah, over time, those first 2 grades, everyone now agrees are not cancer. What he was calling cancer, no one thinks is cancer. So that's, a third of what he said was cancer is not. Actually 40%, right? So now we've got this issue of Gleason's 3, whether that's really cancer or not. And the evidence is becoming really overwhelming that it's not. That again, that grouping does not have the hallmarks of cancer, which would be, locally invading into other tissues, metastasizing, and killing people. And it doesn't do that basically ever. It sometimes progresses to a worse state. That's the one issue, is that it could be a waypoint, of becoming something that would metastasize and potentially kill. But that luckily is very rare. And so now we're left with this dilemma that when the pathologists are grading prostate cancer, they actually give 2 numbers. First, they look at the most of the cells that they're seeing and they grade those. And then but often there's a subset, a smaller number, that look a different way. And so really they end up with a score that ranges, because they add these 2 numbers together, between 6 and 10. That's the current situation that we're in. And that really is very misleading, because the lowest type or the lowest grade of prostate cancer looks like it's in the middle of a scale of 1 to 10, right? You tell someone they have Gleason 6 out of 10, that's like, oh geez, that's pretty bad, when in fact that's the lowest of the low. It's not even clear it's cancer. So there's been a move to actually eliminate the use of the Gleason scores with patients because of this misleading sense that this is way more dangerous than it really is. So we'll look at that. So here's this fact that the Gleason score is 2 numbers, and why it's really important to know what the 2 numbers are and not to just look at the added together number. Because first, Gleason 7, you don't know what that means. If they have Gleason 3 plus 4, so most of the cells are this lowest type and only a few are this intermediate type, that is not dangerous. And I'm going to talk about the studies that confirm this. Similarly, Gleason 8 could be a 4 plus 4 or a 5 plus 3, and it turns out those aren't necessarily the same. So you really want to know, what are the 2 numbers? And if 3 is the first one, this is what I'm calling low grade prostate cancer. But there's sort of a step where we have to make sure it's not an early stage of something that's going to become more aggressive. And as I'll propose, that essentially means everyone has to kind of have 2 biopsies, or potentially MRI or some other tests might be able to substitute for a biopsy. And so, yeah, again, this is just emphasizing how very subjective these categories are, and that another problem I'm going to highlight with Gleason score is that the way they're coming up with this is flawed, and we really need a better system. So very importantly, we've had these large trials looking at men with this low grade prostate cancer, which again, very simply here, I'm defining as Gleason 3 plus 3 or 3 plus 4 on their biopsy. There's no other type present. And so particularly this trial, which was done in the UK, it was published in 2016. So this is one of the most modern of the comparative trials. So they took men who only had Gleason 3 plus 3 or 3 plus 4 prostate cancer, and they randomized them to doing nothing. And I want to emphasize, they weren't telling them to eat a healthy diet. They weren't telling them to take supplements. They did no treatment, or they took their prostates out, or they radiated their prostates. So randomized the whole group. And there was no benefit to these treatments in these men. There was no survival difference between these 3 groups. How could this possibly be dangerous cancer? If this was dangerous cancer, those treatments should have improved the survival, but they didn't. Now, of course, another ominous interpretation of this study is that the toxicity of these treatments was bad enough that if they did reduce prostate cancer death, they increased death due to other reasons so much that the net result was no benefit. And actually, when you look at the details of the study, that is a little bit supported. For example, there was more metastatic disease in the no treatment group, but the cardiovascular mortality was significantly worse in the prostatectomy and the radiation groups. So there's kind of growing recognition of this fact that these treatments, even though they seem local, they're not, that major surgery has effects on your whole body. We know that. Duh, that's what we might say. And same thing with radiation, even though you're only beaming it at one part of the body, it infects it affects the gut flora, it affects the blood, and those things have systemic effects. So what we're seeing is this pandemic of overtreatment. And I say pandemic because this is global. This is not just in one country or something, it's all over. Though it's certainly better in the UK than it is in the US, where we don't have a healthcare system, so people just do whatever they want to make money. Is pretty much how you could summarize the situation here. And at least you have some kind of a system, though it has its own problems. But yeah, everyone hears the word cancer and they get scared. How could they not? Both the doctors and the patients. And so everyone feels like these treatments are to protect against the cancer getting worse, even though the evidence is very overwhelming that 80% or more of these patients won't get worse, it will never spread, and that these treatments have no benefit or their toxicity outweighs their benefit. So I just found another paper, which is of a Swedish trial that's now has 30-year follow-up, because the PROTECT trial had 10-year follow-up. But this Swedish study at 30 years found that prostatectomy compared to doing nothing extends life by 3 years. So they have found a small benefit. But that study, they didn't find these patients with the PSA blood test. They just basically, it was only when it was discovered clinically that they had prostate cancer. So either it had already spread or it was much worse. So that Swedish study is really hard to compare to this study. And in reality, almost everyone with prostate cancer today is diagnosed because of the PSA blood test. So this really mirrors much better what's going on now. So this is the proposal in the conventional world, which this is being widely used now, to use these grade groups to get rid of that problem of it sounding like Gleason 6 out of 10 is worse than it really is. So that's now called grade group 1. That sounds, 1 out of 5, that sounds much milder. I think that gives a better sense. And that is what I really recommend you talk to patients about, that you don't say you have Gleason 3+3 first. Say you have grade group 1, you're in the lowest risk category. And if it's 3+4, that's supposedly grade group 2. I really dispute that. I can't find the evidence that supports survival is worse with this Gleason 3+4. So whatever. I still tell patients you're in the lowest risk group with this finding. And then of course, if they're in grade group 3, 4, or 5, essentially I believe they should have these conventional treatments, but along with naturopathic treatments, to optimize their chances. And so I'm not going to talk about that anymore, because the topic of this is low grade and the fact that we really shine in helping folks with this low grade stuff, if nothing else, by just preventing them being unnecessarily treated, with major surgery and radiation. So in writing the book, I also came across this research, which very frustratingly now is from 2003. It's getting to be almost 20 years old, and there has been no movement to change what's being done despite this. So when they do prostate biopsies, and most biopsies, they use formaldehyde to preserve the tissue. When you do that, it does preserve the cell membranes, but it destroys most of what's inside the cell. And it turns out this radically changes what you see. So in this study, they preserved prostate biopsy tissue with alcohol or other preservatives, not formaldehyde, and they saw this incredible difference. All the stuff inside the cell is also different in cancer cells. So they particularly focused on these three different issues, these things called prostate secretory granules, which is essentially where the PSA is made in the prostate cells. And they look really different between cancer cells and normal cells. And that low grade type Gleason 3 looks like healthy cells. It doesn't have this secretory granule difference. So you can't see this on a conventional biopsy, but if they would just change the preservative they use, it would just completely change the way everyone is talking about this. And so anyway, there's these other things called these cytoplasmic buds that again are very different between the cells that are destroyed by the formaldehyde. And then there's this one other issue. So the most prostate cancer is found in what's called the peripheral zone. And that's the part of the prostate that's the furthest away from the urethra, but only on the posterior side, the side that's towards the rectum. On the front of the prostate, though, the anterior prostate, there's another zone which has very few glands in it, and occasionally cancer occurs in there. And this, again, I really almost dispute we should use the word cancer. Like, this is the lowest grade, lowest risk. And anyway, one of the things they see in that kind of cancer is they develop these lipid vacuoles that they don't see in healthy cells, but they don't see in the dangerous kinds of cancer either. So just as a side note, if someone has transitional zone prostate cancer, if that's the only place their biopsy showed a problem, you can especially breathe easy and say, that is the lowest risk cancer there is. You know, don't do anything aggressive, most likely. Anyway, this, if they had just would improve their biopsy technique with this one simple thing, I think it would really change a lot of minds. So I do have pictures from this study, which, you know, I don't know, I don't think probably any of us are trained as pathologists, but these show these very distinct differences with different stains that would, I think, really improve the grading of these cancers and the recognition that this low grade type is a totally different problem than the high grade type. So, and as I said, unfortunately, this has not been taken up in the mainstream. So, it shows that things could really be improved. And it just fits this narrative we see so often that, you know, medicine is a business, and also people get set in their ways. And it's sort of, well, this is how we've always done it. Why would we change? And it's frustrating because it's obvious why I should change, because it could really improve patient care. So, this problem of low-grade prostate cancer versus high-grade has kind of been going through a change. So initially, especially once the PSA test became available in the mid-'80s, everyone just assumed, oh, this is like the pre-cancerous form, where it's it's going to become high-grade and it's going to spread if we don't do something, because that was the model that had been seen with other cancers up to that point, especially colon cancer, right? Really, our understanding of cancer is largely based around colon cancer. Is there a question? Okay. And in colon cancer, yeah, if you don't do something, it pretty much inevitably becomes metastatic. And that, of course, is because colon cancer is so much easier to access than cancers of organs that are deeper in the body that are very difficult to access. But it turns out this model doesn't apply to prostate cancer, that there's this type of prostate cancer or abnormal cell that doesn't progress And that's what most of the cancer is. We also now see that is true with breast cancer. About 75% of it is non-lethal. We see it with thyroid cancers, where more than half of thyroid cancers are non-lethal. Of course, basal cell carcinomas, squamous cell carcinomas of the skin, most of those are non-lethal. So we see this paradigm that there's this other disease where the cells are abnormal. There's some mutations in the DNA, but they're non-lethal. So initially, anyway, everyone said, oh, this is like colon cancer. We have to treat everyone. We're going to save their lives. And they just would operate and remove everyone's prostate or do radiation therapy. And but the prostate cancer death rate only dropped by 4% when they did that. And that immediately, eventually people started scratching their heads, or after 10 years, you would think the death rate would plummet, right? If you're treating all these cancers, like, why didn't this just eliminate prostate cancer practically, and or the death from it? And so that's why we say there's over treatment. Like, that led to such little benefit. And now the largest studies are saying, yeah, something like 1 in 50 prostatectomies has a benefit to that patient. So that means you're doing 49 operations that have no benefit to save one life. That's really not safe. So then people said, well, the problem is the biopsies that are finding this low grade cancer are just missing the high grade. And so if we just do more biopsies, if we just put more needles in, we're eventually going to find the high grade cancer that was actually there all along. And so, but the result was the same. Everyone was getting treated. More biopsies did find more high grade cancer, but really, again, there was almost no change in the death rate from prostate cancer when this happened. So they went from taking 6 cores to 12 to now 18, when they, 18 needles versus 6. And there's no evidence that's really helped. So now we're kind of in the era of this third approach, where we have all these studies. We have the PROTECT study. We have other studies saying, oh, this low-grade prostate cancer is actually not cancer. It doesn't metastasize, and usually doesn't progress, the vast majority of the time. So now we're going to actually do active surveillance. We're going to not treat. We're going to just watch and make sure it doesn't get worse. But that leads to a lot of biopsies. Some places they're saying to do a biopsy every 6 months, which is a lot of biopsies. Even one a year, if you start getting them at age 60, you're looking at 15 biopsies by the time you're 75. That's usually when they stop doing the biopsies. That's a lot of biopsies. And as we're going to see, because they're doing transrectal biopsies, that comes with a real risk of causing infections. So this has reduced the amount of prostatectomies and radiation that's being done, and the death rate has stayed low. Like, that didn't cause there to be increased deaths. So this is further support for this fact that we were overtreating before. And basically what I'm saying is we can do better. We cannot just watch and wait to see if it gets worse. Of course, we can do things that are safe, that are not surgery and radiation, that actually work and really are going to prevent progression for even more of these patients and help them feel confident that they're doing something. I think that's the problem with just watching and waiting or active surveillance, is people feel like they're waiting to die and they're not doing something. So we give them something to do that we know is beneficial. I'm not saying we're giving them placebo, but even if we're treating their general health, that's a benefit, right? Even the dietary things I'm going to suggest, even if they don't directly treat prostate cancer, I don't care. If we can improve their general health, their body will fight the cancer. But we do have evidence that the things I'm going to suggest fight the cancer. So that, I think, is the way out of this trap, and that we don't have to do so much surveillance for it to get worse, that it's just unnecessary. So yeah, right now, almost all biopsies are done through the rectum into the prostate, which of course, there's all these bacteria in the rectum. So there is a small chance of infection. That's really the main risk from these biopsies, including about a 0.1% chance of dying from a prostate biopsy, a transrectal biopsy. Now, that's a very low percentage, but when you're talking about, I don't know, in the United States, it's at least 250,000 biopsies a year. 0.1% of that is hundreds of deaths a year. That's unacceptable. These are basically healthy people dying from sepsis. So it turns out you can do a biopsy through the perineum and completely avoid the colon. This traditionally has been harder because there's a much bigger pain problem. So traditionally it required general anesthesia, which of course has its own effects. But now they've developed technology that doesn't require general anesthetic. And they've shown there essentially no one dies of sepsis from a transperineal biopsy. There are still sometimes infections, but it's local infections. And so there's a growing call. Here's a paper from last year, including the entire medical system in Norway said we're banning transrectal biopsies. Never do those. They're too dangerous. Do transperineal only. So this is not just like one person out in the wilderness crying out against this. So another really important point is just to really try to steer your patients towards this transperineal technology, which I have no idea how available that is in the UK. It's moderately available in the US. So, and there are definitely several people that co-signed on this paper in 2020 were in the UK. So this is not something that's unknown. And all urologists are trained to do a transperineal biopsy. That's something they all learn. They all know how to do it. It's just whether they actually will or not. And these are the things I recommend with either biopsy, certainly if it's going to be transrectal. So I give echinacea to help get their immune system to fight infection. They're already being given an antibiotic. But by the way, that's the other benefit with transperineal biopsies. You don't have to give an antibiotic. They've shown this because the infection risk is so low. But I'll still give the echinacea because why not? Let's further reduce their risk to as close to a zero as we can. There's a very small chance of spreading the cancer by a biopsy. I think this fear is too high in patients' minds. There is research on this, and it really doesn't, it's very rare that this is going to be an issue. But nevertheless, I give this modified citrus pectin, which is a metastasis blocker. And so that's made from that white inner rind of citrus peels. And the modification is just that they cook it. So they break down these complex carbohydrates, and then it's just dried into powder. It's rather unpleasant tasting. So the product that I use has a lime flavoring added. Does anyone know if this is available? Is this something that you're familiar with or using?
I've not heard of it in the UK, Eric. No.
Okay, so yeah, I didn't know how to investigate that, but it's certainly widely available here. So I suspect it could be obtained, but we'll have to see. So anyway, because the dose is 5 grams, I mean, of course you could do that with capsules. It's just, that's a lot of capsules. I generally use it as the powder, and it will not mix into cold water. So you either have to dissolve it into hot water, or some patients are making smoothies, they're blending up fruit and ice and whatnot, and it does mix well if you blend it into things. So yeah, that's a metastasis blocker. And I'll talk more about how that works a little later. And then if they're going to have a transrectal biopsy, I do give them probiotics to try to counteract the effect of the antibiotic and to reduce infection risk. If it's transperineal, there's no reason to do that. And then if they're just very anxious about a biopsy, they're afraid, I use Kava. I don't remember the status of that in the UK. I know Canada got it back. It had been banned there. But basically a nervine. Give them some nervine herb. You maybe have valerian, melissa, passiflora. You've got so many choices. Or the lavender volatile oil, that's been very popular. Any of those things to just help them feel comfortable and to make it through. And we have other studies of lavender with some other medical procedures, colonoscopies, I think thyroidectomies, they did this to help people with anxiety. And they actually showed reduced need for pain medication after those procedures with lavender. So that's another bonus. And it highlights that a significant part of pain is fear and anxiety. It's not the only part, but it is a part. I did share these slides with Roger, by the way. I'm sure he hasn't had the time to necessarily pass them along, but I believe that will happen.
It will, yes, and I do have them, Eric. Yeah.
Excellent. Okay, good. So just don't necessarily feel that you have to write everything down in terms of doses or whatnot, because you'll have those. I'm sorry, the font turned a little funky here, but so in terms of defining what is low grade, like clinically, what are we going to say? Who is appropriate patient to have this sort of active surveillance plus naturopathic treatment? There are some areas that we don't know. So one of these, which I actually had a patient just this week, where yeah, all he had was Gleason 3+3 and 3+4 in his prostate biopsy. But there were actually 8 of the 12 cores had cancer in them. So the PROTECT study, they limited to patients who had only 4 positive, this is again, like how many needles did they find cancer with? They limited it to 4. So if it's more than that, we don't really know. So I'm still at this point saying, well, it doesn't matter that much. What I tell patients is we don't necessarily know if there's a lot of cancer, but it's all low grade. There isn't research to really know, but I generally will still use this program. I think we probably just have to monitor a little more frequently than what I'm going to recommend. Then another issue is very young patients. So I also had a case of this 2 months ago, which was an African-American gentleman who was diagnosed when he was 54, and he had only Gleason 3+3, but he's 54. He's so young. They put him on active surveillance, and then they didn't really do that much surveillance. Now, that may well be a result of racism in the medical system here. But yeah, now he just turned 58, and the cancer is spread all over his body. And it was just not appropriate. So yeah, when there's a long time ahead, so the average lifespan for men in the United States is around 75. So, when they're under 60, you are really looking at 15 to 20 years that they've got just by the law of averages. And that's a long time for a cancer to change or get worse. So we're only really talking about generally men over the age of 60 is kind of my cutoff. And then we do have to watch out, at least in the States, because there is so much racism for patients of African descent that they tend to not get the appropriate level of care. And this is not biological. There's nothing about being of African descent that makes the cancer worse. Like that has been looked at extensively and no one's ever found anything. It's because of the way the healthcare system fails these patients. So I assume there's some level of that going on in the UK, but again, you at least have more of a healthcare system, but that's something that maybe also bears just warranting extra attention to make sure that that's not creeping in. So I do recommend other tests to help in the monitoring and the assessment of sort of how bad is this cancer. So one is to use the free PSA blood test. This is readily available. I know this is available. It's still not that often used. And this gets at the fact that enlargement of the prostate is also practically inevitable in men who have prostate cancer because they co-occur with age. And as the normal cells as there's more of them, because with benign prostatic hyperplasia or BPH, the problem is the cells, the healthy cells are dividing too much, but they still make PSA. But the way they make it is different than prostate cancer cells. So the free PSA will be higher the more that the PSA is coming from BPH compared to cancer. So free PSA being under 20% does confirm that if the total PSA is elevated, it's because of cancer. But if the free PSA is above 20%, you really have to also say, wait a minute, this PSA test that's making everyone so nervous may be largely because of benign tissue. And then you'll want to assess, which you should be anyway, sort of, do they have BPH? How severe is it? I still recommend digital rectal exams. We know whether you feel a nodule or not on the prostate it turns out that's not really, doesn't tell you anything. It doesn't predict who's going to live or die with prostate cancer, but it really helps you assess how much BPH they have, and in some cases, if they have prostatitis. Both those conditions are common and they can really confuse the testing at least. So I still think this is important. It's kind of been abandoned in fairly large amounts because it was seen as just a prostate cancer screening thing, but really it's a BPH screening tool is mostly what that is in my mind. So another blood test, which also I'm sure is available, though it's little used, is called the prostatic acid phosphatase. So when the PSA test was invented, this was abandoned because this is not a good screening test, maybe. This really only shows up in aggressive prostate cancer. This actually helps the cancer literally digest its way out of the prostate. It's an enzyme that dissolves tissue. So we only see this in aggressive cancers. And I really want this to be under 3 nanograms per mil. If it's above that, that's a very bad sign that the cancer is actually worse, or that if the biopsy only shows Gleason 3+3 and 3+4, that it missed some more aggressive cells. And also we have studies that have watched the change in this over time. So I always tell patients, you have to get at least 3 of these, 3 months apart, because we need to see the trend. And that's especially with treatment. We want to see it going down. If it's going up, that is also a very bad sign of aggressiveness, and you might want to start thinking about it, referring them for a prostatectomy or whatever. So I've found this extremely helpful. We have modern studies that support this. Urologists seem to not know about it, which is shame on them for not reading their own medical literature. So I'm sorry I didn't get those citations in here, but they're in my textbook. Now, this is a test I'm using. I don't know its availability in the UK. I'm running it through the University of Michigan, but they didn't invent it. These are, it looks for 2 different mutated genes that are seen in prostate cancer. And really the one that's important is the second one, which, as you can see, is actually, the individual genes aren't mutated. It's just that they've been moved and fused together. So a piece of the chromosome has been deleted. And when these 2 things fuse together, which have these long, horrible names, TMPRSS2 and ERG, that makes for aggressive prostate cancer. So this is actually a urine test. So you have to do a prostate exam, and then they collect urine. So you're pushing cells into the urine. And this really can tell us how likely it is they have this aggressive cancer. And it's been really helpful also in deciding who should get a biopsy. If they do this and the chance they have aggressive cancer is under 25%, I generally say, don't do a biopsy. The risk of the biopsy outweighs the benefit most likely. So yeah, I didn't have time to research if this is available. Possibly not. It's not the end of the world. And then MRI really has become much, much better at assessing prostate cancer, but it's crucial that it has to be a 3 Tesla machine. Most MRIs in the world are 1.5 Tesla. So this is the strength of the magnetic field that's being used. So it's the older machines just don't have the resolution because the prostate is little, right? It's the size of a walnut to a plum. And these older MRIs were not, didn't have the resolution. So these newer ones, though, really do. So they have a rating scale, which is this PIRADS rating scale. And it goes from 1 to 5. And basically that's based on, again, deciding who gets a biopsy. So if it's a 1, 2, or 3 PIRADS, that's really good. It suggests they don't have aggressive cancer. When it's 4 or 5, that's where that risk goes up, and you would want to think about a biopsy, or if you're doing active surveillance, to potentially upgrade their treatment. So you have a lot of additional tools to try to make these decisions. Again, it's maybe a trick to get this ordered through the healthcare system, but it's worth fighting for us. I'm really finding a lot of benefit from the MRIs, and especially in reducing how many biopsies have to be done. So this is my summary. If someone has the low grade, so they only have Gleason 3+3 or 3+4, it's in 4 or fewer cores, you're going to go ahead and just do active surveillance and natural medicine. Then this is sort of my advice, which is in 1 year to repeat a biopsy, or potentially the 3 Tesla MRI if they're not willing to have a biopsy. And we're certainly following their PSA, free and total, and the prostatic acid phosphatase. If that 1 year biopsy is as good or better than the baseline one, I shift to only doing them every 3 to 5 years. I've only had 2 patients in 25 years who at 1 year had a worse biopsy. So that's extremely rare. That fits with kind of the statistics that are out there. So why you would keep doing biopsies on these patients over and over again who'd have a good biopsy follow-up, I don't know. And yeah, I've so far had no one at 3 to 5 years who had aggressive cancer. So this, I feel, is plenty of surveillance. That you don't need to be doing these every 6 months or every year biopsies. Okay, so what are we going to do? So this slide kind of summarizes my advice. So again, this is now for low grade cancer. This is if they have high grade, these could be used adjunctively, but that's a whole other topic. So I'm going to go through each of these in a little bit more detail and look at the research. But basically, I think the key treatment is to move them towards a more plant-based diet. And this is, depending on their willingness and whatnot, their availability of foods is to kind of determines how extreme to go. Or, for example, if they have 5 or 6 positive cores of the low-grade cancer, I might be pushing for a more aggressive, almost vegetarian diet, fully vegan, maybe even. But it's not like they have to give up all animal products. It's just we're kind of leaning that direction. But the worst problems are red meat, dairy products, the skin of poultry, and egg yolks. All those things, we have really consistent evidence, make prostate cancer worse. And that's the key thing here. They have this low grade stuff. We don't want it to become high grade. And then we have a number of specific foods, which I will comment on several of these that show good activity against this low grade prostate cancer. And so we can tell patients. So I really hate to just tell people what they shouldn't eat. It's like, don't eat this, don't eat that. I like to give them stuff you should eat, and try to find things they like, so that it feels a little more positive. And in a lot of ways, I feel like there's so many vegetables in the world, like broaden out, this really helps you to actually have a more expanded diet. It's not a more limited diet. So I'll talk about all these things in more detail, but this is the summary. So we have lots of studies on plant-based diet to help patients who, so this again, this is for patients who are diagnosed with prostate cancer. There is also evidence of this type diet preventing prostate cancer, excuse me, but this is for treatment. And so the main one are Dean Ornish is a medical doctor who's been very aggressive in studying this. So he did do a fully vegan diet, no animal products, combined with exercise and stress reduction, and followed these low-grade prostate cancers for as long as 2 years, which is not that long. And now 2 other groups have replicated his findings that this really works. It prevents the cancer progressing. Now, even Ornish says you should at least eat fish. He's totally been forced to admit that is good for you. So once a week fish is generally my advice. And then if, again, if they want to have occasionally chicken without skin, if they want to have seafood, I'm fine with that. They don't have to be fully vegan. And another big question is whether goat or sheep dairy products matter. And there's just no research. So all the research has been on cow dairy. So sometimes they'll say, yeah, once in a while you could have some sheep or some goat cheese, as a treat. Because how could that possibly be that big of a deal? This study recently, they just had patients increase their vegetable intake by like 1 or 2 servings a day. And not surprisingly, that didn't cut it. So they could still be eating junk food, processed food, drinking soda pop, doing all kinds of things, smoking, whatever, that we're not exercising. So just small changes in vegetable intake doesn't cut it. It does need to be more generalized. And then these are some very specific whole foods that consistently show benefits specific to prostate cancer. I'll talk about a few others on the next slides. Let's see. Of course, I ran longer than I wanted. I want to leave good amount of time for questions. But so one other major point I want to be sure to make is that we see this real tendency among researchers to want to take the food apart and say, oh, this is the active constituent. So you don't need to eat tomatoes, just take a lycopene pill. I hope all of you know that's absurd, right? There is no way to take a vegetable and reduce it to one molecule and say that's the only thing that matters. That is totally absurd. It doesn't work. It's not healthy. And we've been sucked in with this whole curcumin thing. How can you reduce turmeric to one constituent? Turmeric has been used for millennia all over South Asia. They don't take curcumin pills, they take turmeric. We need to stop giving these isolated constituents. This is nuts. Use the whole plants. Stick with that. Stick to your guns. Don't get sucked into this. Just because the studies are on curcumin mostly doesn't mean that's better. Where's the head-to-head comparison? We actually have studies on whole turmeric for a range of diseases showing incredible results at where the dose of curcumin in them is very low. This is not the active constituent in turmeric. That's a lie. It's not true. It's the marketing that drives this. And so we get sucked into it too. So anyway, I never put patients on a lycopene pill. I take them off. I'm like, no, don't take lycopene. Eat tomatoes, eat other red foods, eat watermelon, eat guava, eat strawberries. All these things have lycopene in them and all the other good stuff, and if they can't tolerate tomatoes, you've got all those other foods. Eat legumes. It doesn't have to be soy. It could be any legume. Eat turmeric, take whole Oregon grape. Drives me crazy. So soy has been studied very extensively. And it's not just the isoflavones in it that are active, though there's a lot of research on that. There are all these other components that show anti-prostate cancer effects. And we do have studies on whole soy showing it's beneficial. But again, it doesn't have to be soy because there is a lot of genetically modified soy out there. You can use other legumes. They really all have these things in them. It's just the soy industry spends a huge amount of money on research, which good on them. They should do that. I wish we had it as much on other legumes, but you can have people eating peas and other beans. It's just great. So lots of studies on the isolated flavones as well as various kind of sub forms of soy showing a range of benefits. These are all small studies. This is not super overwhelming, but it looks very promising. And then flax, I kind of put in that same group because of its anti-estrogen effects, which definitely is part of what drives prostate cancer to get worse. And so we have this very nice study on 30 grams of flax meal a day, very easy to eat, showing real benefits, where in this case, they were going to take their prostates out. So that's extreme, but they showed a real direct benefit on the cancer cells, that this is really significantly stopping the cancer from proliferating. So that's promising. Selenium has been very confusing, which again, I mostly think it's because we're extracting selenium from its food and giving it in pills. The way that selenium is in our food is not what's in most pills. It's not bound to methionine. It's bound to other proteins. And actually, there's very scary studies that selenomethionine supplements make prostate cancer worse. So in particular, these early studies with selenium-enriched yeast, where it was bound to proteins, showed this dramatic benefit for prostate cancer, while these studies with selenomethionine showed no benefit. Admittedly, this other more recent selenium-rich yeast study didn't confirm the earlier studies, but there certainly was no worsening. So I just tell patients to eat Brazil nuts because 3 to 4 Brazil nuts gets you 200 micrograms of protein-bound selenium. There's no study specifically on Brazil nuts, but that's, I think, a little closer to nature than the yeast supplements. So low vitamin D is a big driver of prostate cancer, so getting that boosted up. I find almost all my patients have to get to 10,000 units a day to reach this. And, I'm in a very cloudy place, like a lot of the UK. So I think that matches what you're going to see. And I gave in that summary table the blood levels that I aim for. I think I did. Yes. So I try to get them into the 150 to 200 nanomoles per liter range is what I'm targeting the dose to. That's the 25 hydroxy vitamin D3. And then I generally use the turkey tail mushroom in a capsule because it is edible. It's just not particularly tasty. And we have so many great studies of this for every other kind of cancer, extending life by many years. We were actually doing a study of this in prostate cancer at Bastyr University when we lost our funding in a big political mess that happened in the mid 2010s. So we did do a rodent study that showed really good results. Other people have shown that. But yeah, these other studies where I do that. But I have people eat other mushrooms, shiitakes, really any kind they want. And then finally, I wanted to talk about this citrus pectin stuff a little bit further. So it's important to remember that metastasis is not random, that cancer cells actively talk to the cells where they're going to move. So in the case of prostate cancer, it's usually to the bones. So years before it spreads, they've been able to show the prostate cancer cells start telling the bone to basically build them a house. They change those cells' behavior, and then they move there. They don't randomly bump around in the blood. They actively are going to a specific address. So they tell those cells with these chemical molecules to change their address, which are these molecules called gallectins. These are glycoproteins. So this citrus pectin gloms on to those address molecules so the cancer can't see them. So it doesn't know where to go. And so this has been shown again and again in all kinds of preclinical studies. The one clinical trial was in prostate cancer patients. So very, very safe. Occasionally it causes digestive upset. That's about the only thing I've seen. And it is on the expensive side. But it's like, wow, if we could even reduce the risk of it spreading 10%, that's worth it. You know, that's a life-changing event. So yeah, I found that to be really great. All right, I know I've gone a little later than we wanted to ask questions. This is kind of on a whole other wild hypothesis. So what I want to do is pause and answer questions. And then we could, if people want, I can definitely talk about this last little random thing.
One very interesting point you made, Eric, which I think is really the basis of naturopathic treatment, is the participation of the person with low-grade prostate cancer in their treatment of it. They feel that they are doing something themselves, which is, you know, very much the education side and the treatment side of naturopathy. So that I would certainly approve of.
Yeah. And it gives people hope, and not false hope. I don't tell them I can cure your cancer 100%, but it's like you're actively taking steps, you're taking responsibility, and yeah, positive attitude and hope are therapeutic.
Yeah, yeah. Do you feel that prostate biopsies risk spreading the cancer? In other words, promoting metastases?
Yeah, again, there's 3 different lines of evidence that say that's extremely rare, and that including the fact that, you know, the number of prostate biopsies tripled after the PSA test came out, but the cancer death rate went down. If biopsies were spreading cancer, the death rate would have gone up. So I really think that's not the problem. The problem is the infections, which are also getting more and more antibiotic resistant. So that's where I really focus. But I do go ahead and give them the citrus pectin just because some patients really are concerned about that, and I want to, again, address that at some level.
Can I just say something? Firstly, thank you for a wonderful presentation, Eric. Just something you were inquiring whether there was any other form of testing for the cancer cells in the prostate. And here in London at the doctor's laboratory, there is a test which massages the prostate, gets some fluid out, and it is then analyzed. I'm not sure whether they're doing the right thing with analysis, but we have sent some patients there for that, and so they're spared the invasion of the biopsy. They bring in somebody to do it who apparently was the father of it. So that in case I don't know if that's of any interest at all.
Fantastic. No, I'm very interested. Thank you.
Hello, can I speak? Yeah, I'm trained in naturopathic nutrition. I trained with one of the other ladies, Gillian Crowther and Lucy Leaders, trained me as well. But I'm also a patient. And interestingly, I'm about to get my second biopsy next week, which will be a perineal biopsy. I've had the transrectal biopsy about 2 years ago. Then I got missed by the system for a year and had an episode of urinary retention at Christmas, which was a lot of fun, as you might imagine. I've had an MRI about 2 months ago, and they want to now do the second biopsy. But that's over a period of about 3 years. So in the UK, that's what they tend to do. They'll do the transrectal first, and they'll move up to the perineal. I didn't know about the pectin, so I've gone and ordered some. You can get it in the UK. I've double checked in my supplier, and it's very expensive, but I've ordered some anyway. So I'll be pleased to use that. I'll report back to my friends and colleagues, and I'm sure they'll feed back to yourself as well. So really, really pleased that I've been able to attend this talk, and thank you very, very much indeed.
Absolutely. Thank you for sharing. And yeah, I hope that all goes smoothly. And yeah, you definitely know the things to do.
Yeah, I was just going to say it's comforting to know, Stephen, isn't it, that the biopsy isn't such a problem after all, because
Yeah, that's really good, isn't it?
That's what one had feared a little bit. We just have to be careful of the infection.
That was more with the transrectal than the perineal. Yeah.
Yeah, just switching to the transperineal is a huge positive step. Yeah, I really am glad to hear that. And do you know if that MRI was the 3 Tesla? Did they mention that, or
I
did
don't
that
know,
come?
but I'm going to ask that question and find out. What I did do is I refused to take gallantium. They tend to always use contrast in the UK.
Oh, the gadolinium, Stephen, was that?
So I refused. They didn't like it, and they said it was difficult to read the results. But so be it.
So be it. Yeah, it's unclear to me how important that is, and I agree that that should be reserved for absolute necessity. The kidney harm of the gadolinium is a little shocking, though they have been changed. So the gadolinium is always hooked to another molecule, which they think is the big problem. But yeah, it seems like mostly it's unnecessary for this purpose.
Seems to be. Oh, sorry, go ahead.
Go ahead, Gillian. Go
I was
ahead.
just going to say it seems to be dotarem that they primarily use here in the UK. I don't know which molecule that is that they're hooking it to, but it can be very harmful. I have about 6 patients who've found it almost impossible to detox and have suffered severe disability after being given 1 or more gadolinium MRIs.
Yeah, I don't think any of them completely eliminate the risk, and I can't recall either if the dotarem is one of the better ones. But yeah, it is concerning.
Yeah. Could I ask Eric if the modified citrus pectin would be also so efficacious for other cancers, breast cancers and other forms as well? Would you include that in the general protocol?
I do. So we don't have clinical trials that I know of for any other cancer, but we definitely have animal studies and cell studies that support the same. Metastasis, it's the same for all cancers. They're doing the same thing. And it involves these galectin receptors, and the citrus pectin does block that for many kinds of cancer cells. So yeah, I do think that's a general cancer recommendation.
That's very interesting.
Thank you. That's great.
And then, so that confuses people because of course there's apple pectin, and that's really, really cheap. So people are like, can I just use apple pectin? And unfortunately, they're very different, the structures. So that's not a workaround. And then people wonder, can I just eat the whole peel of citrus? And I don't know the answer. Again, they do cook it and grind it into powder, but it's at least theoretically something people should maybe be considering. Of course, we all have had probably candied citrus peel, but I think, don't they cut away the white part of the peel when you candy citrus? I have never actually done it. I should ask my wife, she has done it. So yeah, anyway, I'm not sure you can eat your way around to that. You're gonna be stuck paying a lot of money, unfortunately.
What is meant by modified citrus pectin?
Yeah, it's just that they cook it and they grind it to powder.
Oh, right.
Yeah.
Thanks.
Yeah, luckily nothing more scary than that happens. Oh, you're muted, Jillian.
Sorry. What do you do when a patient comes to you and is very convinced after reading Professor Thomas Seyfried and so on that the ketogenic diet is the way to go? Do you say that that's never the case, or is there some testing that might suggest that it is suitable for some patients?
So I will talk about that the research is overwhelming on the plant-based front. And then I also point out the ecological problems with a high animal product diet, which is, the methane production by cattle raised for food is at least 10%, if not more, of what's driving global climate change. So it's just not sustainable with billions of people to eat large amounts of animal products. So if that doesn't convince them and they really, really won't budge, then I do find there's some benefit because they are tending to cut out all the other stuff that's unwanted. They know they can't eat processed foods, and they're generally avoiding simple carbohydrates, and they also do tend to increase their vegetable intake quite a bit. So I try to just steer them away from like the poultry skin and the egg yolks, and just see if we can maybe, instead of doing it with, beef, like maybe do it with chicken or fish. And so it's been a range, but yeah, so I think you can work with that and kind of modify it, as opposed to, yeah, putting your foot down and saying, no, that's bad. That just makes people defensive. So yeah, I try to work with them, and that's generally gone well.
Thank you. Especially in the States, there's such a trend towards the ketogenic diet, isn't there? There's so many books.
Yeah. So many. But it's kind of starting to burn itself out. I mean, I have had many patients said, yeah, I did that for a while. Initially, it sounds like eating bacon all the time is heaven. And then you realize it actually becomes disgusting and you can't stand it anymore after a few months. It's like, I never want to see or smell bacon again. It's horrible. So yeah, there is a limit. Yeah. But it has helped. It has definitely helped people. And again, I think people put too much emphasis on the more animal products piece and not the less carbohydrates, more vegetable piece of it that comes with it. So,
and the good fats as well.
Yeah, that's right. Yeah.
I'm interested to see the varicocele hypothesis, because a colleague of mine actually went to Israel to have this surgery, and was very optimistic about it. But I see that trials have only been done for benign prostate hypertrophy and not prostate cancer. Although I would hope that it would translate for prostate cancer as well, to reduce the risk at least.
There's been only one study done by the originators of the theory for prostate cancer. So this is a group in Israel, as was just mentioned by Roger. And so they treat this varicocele, so varicose veins of the spermatic veins, that are most noticeable because then the pampiniform plexus dilates. So this is very easy to detect, by physical examination. Anyway, so they were treating these patients, and I don't know what led them to do this, but they were doing sclerotherapy. So that involves, so they're radiologists. So that involves, introducing a needle into these varicose veins and injecting saline. Then the scar tissue basically helps compress the veins and counteract the varicocele. Well, anyway, since they were already in there with their needle, they were sampling the blood coming out of the prostate. So this is not something you can do routinely, right? They have to be under anesthesia. And so in these patients who had varicoceles and enlarged prostates or low-grade prostate cancer, they found that the blood coming out of their prostates had as much testosterone in it as was coming out of the testicles. And they're like, what? That doesn't make any sense. It's like the testosterone gets dumped into the blood coming out of the testicles. It's diluted through the whole body before it gets to the prostate. It should be much, much lower. And what they discovered is there are these tiny little deferential veins that attach the pampiniform plexus on both sides to the prostatic venous drainage. This is not to scale. Obviously, the testicles are not this far apart. This is a very simplified diagram, but so what they were showing is that the varicocele was causing testosterone to back up into the prostates. So yeah, at a level that's 100 times higher than what we find if you draw blood from your arm. That level is like 1%, what we find coming out of the testicles. So their approach was to basically sclerose those deferential veins, but basically to treat the varicoceles. And they showed prostate shrinking, and they showed in several patients their low-grade prostate cancer was gone. It went away. So several other groups have done this treatment, or they've done microsurgery, which is more common in the US at least, to treat the varicoceles. And they've shown it, like I think 3 different groups have confirmed that the prostates shrink, but no one else has looked at the prostate cancer, only the originators of the theory. So yeah, I've had one patient go to Israel to get treatment by the Gat and Goran, who came up with this, and for prostate cancer, and both of them did have regression. Their follow-up biopsies could find no cancer. I've had 2 patients also get their enlarged prostates treated. And now I've finally gotten a local urologist to agree to do this. So I'm very excited because this is minor surgery. You know, this is dramatically less invasive than anything you would do directly to the prostate. You know, you're in and out of the hospital in an hour. It's really, really minor surgery. So surgery, yeah, it's like, oh, that's not ideal. But it also, to me, highlights the potential preventative benefit of a healthy diet in children. Like varicoceles and varicose veins start developing in childhood. We only think of them being in the elderly, but I see teenagers with varicoceles not that uncommonly. And they eat terrible diets, right? They don't have fruit and veg in their diet. And it shows like the tissue quality is degraded. So the answer to preventing it is earlier life interventions. And you know, you're probably not going to tell a teenager, if you eat more fruits and vegetables, you're going to have less prostate cancer. Like they're not going to listen to that. But at least for the males, if you tell them it will help their sex life down the road, that catches their attention. So that's the hook I use. But yeah, anyway, very, very interesting. And I think it needs to be more widely known and considered, especially if they're thinking about doing a prostatectomy. You know, this would be a much milder surgery to see if they could avoid that.
Indeed, indeed.
Did your patient who went to Israel have any joy, Roger, or don't you know yet?
Oh yes, he's very happy. He had early signs of benign prostate hypertrophy, which have now disappeared. All the symptoms that he was getting have disappeared.
Oh, brilliant.
Fantastic. Can we ask the name of the center, you know, to refer people to in Israel?
I can check and let you know. I can find out. But I know from the UK, I think he took, this is just prior to COVID. I think it was in 2019 or something. I think he took a Ryanair flight to Tel Aviv, I think, which cost about £40 return. And it was a day surgery, and he stayed there the night and came back the next day. So it was very, very quick.
Wonderful, wonderful.
I know with the one of my patients actually couldn't go because it was when not this current outbreak of war, but the prior one, he actually couldn't go to Israel. They closed all the commercial flights. So they apparently will also fly when that happens to Cyprus and do the procedure there. But anyway, it's called I have their website. It's called the Goran Clinic.
Goran Clinic.
Goren. That's another one of the researchers' names. So GAT, here's the name.
Thank you very much.
Yeah, if you just Google that, you'll.
Thank you, Eric. Thank you so much for the time you've given us talking about this. It's obviously a very important and a common occurrence cancer. I think it's the 3rd most common cancer after lung and breast. So just to wind up, thank you everyone for your interesting questions, and also very much, Eric, happy birthday tomorrow.
Thank you.
Yeah.
Oh, happy
birthday.
Yes, happy birthday.
Thank you. Bye-bye, everyone.
Have a good night.
Bye-bye.
Thank you very much for the wonderful presentation and invitation. Thank you.
We'll all be getting your book as well.
Very good. Enjoy.
And thank you, Roger, for bringing him to us.
Thank you very much.
Birthday boy.
Thank you, Eric. Goodbye, everyone.
Bye.
Bye.